Okay, why don't we all try to get our seats. We have a full and exciting day coming up. And I just want to make sure, since the doctors were meeting at the workshop on this floor yesterday, I want to make sure that they know so that the workshop itself is actually being held downstairs on level 2 today. And that will be occurring for the rest of the day for the workshop. Meantime, the summit will take place here on this lovely floor for the next 2 days. And so you probably have already, come to the conclusion there's a lot of people interested in Waldenströms in this building today. And I think it's probably the largest collection of people that has ever been assembled that is interested in Waldenströms in one place. For the last 2 days, the International Workshop on Waldenströms has been meeting and deliberating, and it's been a very exciting meeting. And the purpose of having the summit happen simultaneously is to be able to disseminate all the exciting progress that's happening in this disease. Jan Waldenström once said that we would be able to conquer macroglobulinemia after careful molecular dissection. And I can assure you, it is being carefully dissected, based on all the presentations. We, in fact, have been running overtime constantly with all the presentations. We have over 100 presentations being made on Waldenströms in the workshop itself. And that just speaks to the fact that there's a greater and greater interest in this disease and in making progress. When we had our first workshop, we had 19 people. It was basically a half-day meeting, and we had really no agenda. We just had a collection of interested people, and all we could agree to was all the things that we didn't know. So you think about that. And now, even 3 full days, we're not able to capture all the progress that has been made since our last workshop. That's how much things are changing, and we can all feel good. The purpose of the summit is really not to just bring together, doctors and patients together. It's not about bringing, teachers and students. It's really being able to bring partners together because we learn from each other. And that was another wonderful attribute of Jan Waldenström. He loved to listen to his patients and learn from them. And this is really the opportunity that we also have now here collectively to learn from one another, to understand from one another what's important. You're going to hear a lot of progress. Some of it may be over your head. I can assure you it was over our head downstairs. But we're going to have the opportunity to ask a lot of questions. I don't want you to be shy about asking questions. If you don't know, or confused or may not really understand it fully, that's the purpose of these mics, and that's what our speakers are here to offer. So I don't want to belay here the introduction, but I do want to be able to introduce 3, incredible human beings that I have worked with in this field that have, kindly agreed to be our local organizers and are just great people who have made great contributions to medicine. And individually, I want to introduce you to them. Rick Furman, please come up. Rick is a professor of medicine at Weill Cornell, an incredible teacher. I've learned so much from him, but he's really been at the forefront of introducing all these new drugs to the B-cell malignancies, including Waldenström's, and Ibrutinib is one of those drugs. You'll be hearing about other drugs that Rick has also been involved with, but please welcome Rick Furman.
Thank you, Steve, for that introduction. This is really, I think, a great honor and a great pleasure to be here because it really, the reason why we do all that we do is for all of you. And it really means so much to us as physicians to be able to partner with all of you and really help together to work to really actually fix this problem. And, my hope is that we very soon will be able to say that Waldenström's is a disease that won't impact life expectancy, that it won't impact quality of life, and it's just something that we could sort of treat just like high blood pressure. And it's sort of with that idea that, as we learn from one disease to the next, we really can help to knock down all these obstacles. So I thank you all.
And next, I'd like to introduce Leah Palumba, who is a faculty member at Memorial Sloan Kettering. And Leah has also distinguished herself in Waldenström. She was a member of the clinical trial team that made Ibrutinib possible for Waldenström's, and in fact, the approval for Waldenström's, making Ibrutinib the first ever approved drug. And so please welcome Leah Palumba.
Thanks. First of all, if you're here today, it means that you either have the disease or have a relative with the disease and you want to stay informed. We spent the past 2 days locked in this room from 8 in the morning to 6 in the afternoon, speaking about what's coming and all the new therapies, and there is a lot that is incredibly promising. That it looks like you're never going to run out of options because there are options coming up all the time, and we're understanding this disease more and more to the point that we will probably get to the point of eradication, and that is the goal, our goal and our promise to you, that we will work towards that goal. So thank you very much. You will be inundated from, a bunch of new notions, but it's fun, and ask, as Steve said, ask the questions. We're here to answer, and we're here to learn from you because, hearing your feedback is incredibly important for us. Okay? Enjoy the day. We will be going up and down between this meeting and the next meeting, so you will see us again.
Great. And then finally, I want to introduce another colleague and friend, and this is Dr. Jorge Castillo from the Dana-Farber Cancer Institute. And Jorge, as you know, assumed the leadership of the clinical component of the Bing Center for Waldenstrom's macroglobulinemia, and has been a very active researcher both on the translational side as well as clinical side with new trials for Waldenstrom's. Please welcome Jorge Castillo.
Such a great honor for me to be here. I see you, and I see patients of mine, I see friends. I do. We all have, you have, if you're my patient, you have heard me saying this. Waldenström is very heterogeneous. It presents so many different ways. Patients are diagnosed in so many different ways. It's like getting to a place, taking different roads and different routes in different ways. So some people come by train, by plane, by cab. But we're all in the same boat now, all of us. And at the end of the day, it's going to be our work and your work. I haven't seen a group of patients more dedicated to learning about their own disease as patients with Waldenstrom's. I haven't seen it anywhere, and I'm really fascinated by it. So you and I and us, I want to work together to try to get to the bottom of this and fix Waldenstrom's. So thank you.
Great. And our next speaker will be introduced by Dr. Castillo. He'll be introducing Carl Harrington, who is the president of the International Waldenstrom's Macroglobulinemia Foundation.
Steve said everything already. What else am I going to say about Carl? Carl Harrington, the president of the IWMF. Under his leadership and his direction, the IWMF has been able to amass a staggering amount of members, an amazing amount of support for research for Waldenstrom's, to try to understand the biology of Waldenstrom's, to try to treat Waldenstrom's, diagnose Waldenstrom's, prognosticate Waldenstrom's better. It is truly an amazing organization. You all know it's a patient-led, patient-funded, patient-supported. One more example of how Waldenström patients are just different. And I like that. Carl Harrington.
What do I do to make them come up, Doug?
Click on that link.
Click on which thing? We've practiced this a lot.
That's why I'm here.
Boy, that's really technical.
I know, I know. You good?
Yes, I think so. Well, good morning. As you can see, I am very technical. And I'm Carl Harrington. I'm the volunteer president of the IWMF. If any of you are doctors, you're probably in the wrong room, but you're welcome to stay. Last chance. Okay, this is the patient part of the meeting. Not going there yet. I want to welcome you to New York City and to the 5th International Patient Physician Summit. Now, what's going to happen now is this is probably the most understandable presentation you'll hear today. There's the fewest acronyms and the fewest words that you can't pronounce, because I'm going to skip over the ones I can't pronounce. And like most of you, I am a WM patient. I was diagnosed in July of 2006, and like most of you, I was scared to death. But I'm still on watch and wait, which I'm pretty happy with. So I want to start with this cartoon. Now, I imagine you all can't read that. So for those of you in the back, or for those of you in the front, what it says is you have a condition that is very hard to pronounce. And I don't know what condition he might be talking about. You'll notice during the day that I will be talking about WM. I'll be talking about the IWMF. And sometimes when I meet with people, like say from foundations, or not from pharma companies, they want to know how to pronounce it, and I say, well, you just sounded out, foundation. But that's apparently not the word they have trouble with. You know, the IWMF is a global, volunteer-led and volunteer-funded nonprofit that's focused on WM. And you're going to see that picture a lot, but that's the guy who discovered our disease. Now, we have a very small staff in Sarasota, Florida. But the IWMF, as Dr. Castillo said, is led and funded by WMers. I'm a volunteer. All the board members are volunteers. All the support group members are volunteers. The people who make the torch are volunteers. Everybody's a volunteer. So last year, our office spent about 15,000 hours working on our disease, but the volunteers spent about 35,000. So it's no wonder that we're able to get a lot done with low expenses. Okay, now, when I do these things, I always want to find out who's in the audience. So some of you may have seen me talk before, and you know that you have to put your coffee away because I'm going to make you stand up and sit down. So you ready for that? Everybody ready to stand up? Okay. So if you're a caregiver, would you please stand up? That means you don't have the disease. You could be from a pharma company, anybody. All right, you patients, give these guys a round of applause. Thank you. Okay, now I want all the patients to stand up and stay standing. If you're a WM patient, stand up and stay standing, if you can. Okay, look around. There's a lot of people in this room. Now, you're gonna get to sit down in stages, okay? So if we're diagnosed in the last 2 years, go ahead and sit down. Quite a few. Look around. You guys who just sat down, look around at the ones that are still standing. You want to find a veteran WMer to befriend, because you really do want a friend who's been down this road before. Okay, so if you've been diagnosed in the last 5 years, sit down. These people, make sure you know these people. There's still a ton of people standing, so would everyone diagnosed in the last 10 years sit down? Now, doesn't that, for you guys that were just newly diagnosed, isn't that nice to see all those people still standing? Hey, I'm one of them too. I get to stand. I'm not going to go further because then I won't be able to stand, but anyway, you can all finally sit down, thanks. And lastly, would everybody who's outside the United States please stand up from outside the United States? Thank you for making the long trip. We know it'll be worthwhile. So no matter where you live, I want to make sure you understand that with the IWMF, you are not alone. It's a very scary disease when you're first diagnosed, but you're not alone. As you can see from this chart, and again, you can't read all those, but we have 18 affiliates now around the world, and probably from where you are, 19 counting the US. Let me take you through a little bit of our history. We were started in 1994 by Arnie Smokler, who was a retired pharmacist in DC, and he wrote to the National Organization of Rare Diseases, NORD, it had to fit in that one acronym, in search of other fellow WMers. And remember, this was before HIPAA, this was before internet, this was before there was even a standard definition of what the heck Waldenstrom's was. But fortunately, writing and ink and the post office had been invented. So that organization wrote back and gave him the names of 21 people. And he wrote to each one of them individual letters, and they all wrote back and said, yep, we want to join. So they all joined up, and that was how the IWMF got started. Today, though, there are 16,000 people around the globe, so you're not alone. And more members means more power, more resources, more clout, and more chance we'll get to a cure. So if you're not on our list, please join. And Dr. Tran told me he thought a lot of you may not be on the IWMF membership list. I see a lot of people I know, but if you're not, stop by our table, email us. Everything we do is free. Now, the initial focus of the IWMF was on providing education and support to people affected by our disease. But in 1999, we started funding research because nobody else does. We don't, for those of you from overseas, we get no government funding. All the money comes out of the pockets of people like the ones in this room. And since then, we've funded $14 million worth of research, and that's been instrumental in a lot of the progress that's been made. I'm not going to read all this to you, but the vision of the IWMF is simple and compelling. Support everyone affected by WM while we advance the search for a cure. By everyone, we mean everyone. We don't really care if you're a patient in Indiana or you're a caregiver in India. We don't really care if you're a local oncologist in London, England, or you're a newly diagnosed person in London, Ontario, Canada, or you're a relapsed patient in New London, Connecticut. If you need help, we'll give it to you, and we'll give it for free. Now, the first thing we do is we do support in two ways. We do education and we do emotional support. By education, we do a number of things that you can see on this slide. We have an annual Ed Forum. How many of you have been to an Ed Forum in the past? Good. Well, the last one was in Rosemont. Anybody at that one? Good, you've seen my act before. Well, we had record attendance there. We had over 375 people, and the ratings there were like 4.84 out of 5, so people thought what we were doing was pretty good. In June of 2019, our Ed Forum is going to be in Philadelphia, about 5 blocks from where I live. That's not why we're having it in Philadelphia. But if you can make it, write down those dates, June 7th to June 9th, 2019, and come to Philadelphia. If you like what you see here, you'll like what we do maybe even better because it's 2.5 days. It's got a lot of breakout sessions and lots more time for you to interact with each other. And if you can't come to Philadelphia, we have affiliates around the world who also hold Ed Forums. In 2018, over 1,800 WMers have met at Ed Forums around the world in places like Chicago, here, and Canada next week, the UK, Australia, Italy, France, Germany, and Spain. And if you add in those who attended the cancer care webinars, over 4,000 WMers have been to an educational event this year. That's pretty good. Any of you go to attend that webinar, like the cancer care webinar with Dr. Castillo and Dr. Okay, good. Well, there'll be more of those. And if you haven't been to the IWMF website, make that your top priority. Although it's written in English, it's translatable to over 100 languages, and it contains a wealth of information on everything WM, and includes all the presentations made at the most recent IWMF Ed Forum Rosemont. So if you haven't seen those, you can watch those. They're actually taping these, and you can be able to watch these in a few weeks too. And they're all free. And if you're not receiving the IWMF torch, is there anyone who doesn't get the IWMF torch here? You got to sign up. It's great. It's like a little magazine just about all things IWMF, and it's free, and it's written by our volunteers. Now, we also make all these publications. I'm not going to read all those, but those are also available for free, and they're downloadable on our website. But if you have time for just one publication, make it this one. Our frequently asked questions, it's the most frequently downloaded publication, and it really is written in simple language. We have a test that if Carl can understand it, it's probably ready to go, because I can't understand a lot of things. And now this one, we're going to go in infinite detail. We're going to examine each one of those check marks. All right, the reason I want to show you this on the next slide is there's a lot of check marks up there, aren't there? Well, those check marks all indicate a language that our information is available in. So some of you might be sitting there saying, well, my English is pretty good, but it's not my native language. You know, it's really hard to understand all this medical stuff if it's not in my native language. Well, we've got this now in 7 languages, in English, in Spanish, in French, in German, in Italian, in traditional Chinese, and also simplified Chinese. So at the very least, you can use our website as a way to learn foreign languages. All you got to do is like read it in English and then read it in Chinese, and pretty soon you'll be fluent. It hasn't worked for me. And so here's the rest of all those publications. And look, there are even more checks. And remember, these are all downloadable, they're all free, and they're all available 24/7. So if you wake up in the middle of the night wanting to know something, get the publication. Download the frequently asked questions, and maybe we'll have the answer for what's bothering you. And if you need more information, head to our website, www.iwmf.com. Now, besides that, we also do support. We have 18 affiliates, I mentioned, that cover nearly half the world's population. We have 65 support groups where you can connect and learn from others, WMers just like you. We have IWMF Connect, where you can, basically it's a bulletin board, you can talk online with each other. And that reaches over 2,100 WMers, and there are also local versions in Italy, the UK, Australia, and France. And our lifeline, if you don't live near a focus group, if you can't type worth beans, you can always talk on the phone. So you can talk one-on-one with somebody. We have over 56 volunteers who talk in 44 different topics, including native speakers in Japanese, in Arabic, in French, and Spanish. And we have 2 main Facebook pages that each reach over 2,000 people. In addition to those 2 global pages, we have local ones in Scandinavia, Canada, Spain, UK, Argentina, Australia, China. And in case you don't know, I'm not a big Facebook user, but in case you don't know, I'm told that it's very easy to translate any language on Facebook. So somebody can be writing it in French, and you can easily translate it to English or to traditional Chinese that you've picked up from looking at our website. In 2015, we established the IWMF-LLS Strategic Research Roadmap to identify where we needed to focus our research efforts. And these 4 pillars were identified. The first one is signaling. What's that mean? Well, that really means what pathways do WM cells use for communication? How do they talk to each other? Because they all coordinate their actions. If we can mess around with how they talk to each other, we can mess around with their life expectancy. Immunology or immunotherapy. How can we better use our own immune system to attack WM cells? Because they convince our cells that, hey, I'm okay, nothing going on here, walk on by. And we need to stop that and get our own immune systems attacking that. The tumor microenvironment, how do the bone marrow and tumor environment affect WM cells? You'll hear some of the doctors probably talk about wanting to make WM cells homeless by kicking them out of the bone marrow, because it's too cozy in there for them. We want them to be uncomfortable. Actually, we want them dead, but that's another thing. And then omics. Omics is what else can we learn about genomics, epigenomics, and mutations in WM cells. So what we did is we got the smartest WMers doctors in the world together and come up with this list. And we've been using this list to then make requests for proposals around the world to the best doctors. And since we first issued the first one in 2015, we've done 10 research projects. And these aren't just ordinary research projects. They're all for $400,000 over 2 years, and that's enough money to get the attention of the best and the brightest. So we've been able to get some of the best lymphoma doctors and the leading minds in WM to apply. And so far we've been successful, because we've got, of those 10, we've got eight new doctors we've never funded before, at 7 institutions we never funded before, and 4 from countries we never funded before, namely Italy, Spain, the Netherlands, and Germany. So we've got the best and brightest people in the world working on our disease. So those of you who were in Rosemont saw a version of this. Basically, the theme there was closer than ever, and closer than ever to what is closer than ever to a cure. And I just wanted to show you that in 1994, we had 4 treatments, and they were fairly brutal. The side effects were pretty nasty. Some of you might have even had some of those. And now we've got 30 at least, maybe more. And these are all, we have, including Ibrutinib, the first and the only one that's approved for the FDA. And they're all better with fewer side effects, deeper remissions, and longer lasting remissions. So we are getting closer to what Dr. Furman talked about, making this a manageable disease like high blood pressure. What we really want to do is make it go away, but we'll settle for that short term. In 1994, nobody had any idea what life expectancy was for WM. And when I was diagnosed in July of 2006, I read 3 to 5 years. I didn't much enjoy that. I had a son, I thought it'd be nice if I could see him graduate from college. He's graduated, married, all that kind of stuff. But now that's grown first to 6 to 10, and now if you talk to Dr. Trian, you'll hear him saying 16 to 20 years. And since the average age of diagnosis is around between 60 and 65, that's pretty close to normal lifespan. We want to make sure we all have that normal lifespan and that the quality of our life is there. So this week, we're going to go through each detail of this. We're going to see how many of these I can pronounce. And the answer is 3. And but just listen to these as you listen to the doctors this weekend. But in particular, listen for those top 3. Venetoclax, you might have heard about that. You might have heard about Ibrutinib, and you might have heard about Zanubrutinib. Those are new versions of Imbruvica. But all of them are things that some of you may end up taking in the not too distant future. And the most important part about this chart is there's a lot of things on that chart. So there's a lot more treatments that are coming that are going to be better, safer, and give you longer remissions. In 1999, we'd funded 0. We've now funded $14 million worth of research and over 45 different specific programs. And every single one of those dollars has come from WMers, their patients, their family, and their friends. So please support us if you can. We'll put it to good use. 100% of your dollars go right to research. Today we have over $5 million invested in 13 different projects around the world. And that means that when you get up in the morning, there's some smart guy working on our disease. When you have lunch, there's another bunch of smart people working on our disease. When you go to bed, there's some other brainiac working on your disease. That's very reassuring to me, and I hope it is to you. Just think about that just for a minute. Another way to say that is the sun never sets on WM research. So we've got that sucker on the run, and we want to keep it on the run. The sun also never sets on IWMF support. We now have affiliates in 18 countries. We have over 65 support groups globally, and our materials are translated into 7 languages, and they're available on our website 24/7. So in conclusion, if you're not a member of the IWMF, why the heck not? Go online and join. It's free, and together we can do great things. Remember, with the IWMF, you're never alone. Thank you. Okay. Who introduces whom next?
All right, so I guess we will get started. I mean, there's no reason why to delay things. Is Dr. Owen here? Oh, please. You were out of my vision field. Thank you. Okay, so Dr. Owen here and I have been assigned the job of talking with you for the next 45 minutes or so on what it is MYD88 mutations as well as CXCR4 mutations, and what is the importance of having these mutations or knowing about these mutations in terms of the diagnosis of the disease, if they can be helpful in making in the management of the disease and also in treatment decisions with regards to Waldenström. Let me see if we can. So we want to start with just a very short presentation. We want to basically just let you know what we have or what we know until today, and then we'll open up for questions. I think at the end of the day, that's the most fruitful interaction that you and us can have. What I would like to ask you in general, for not only for this session but also for the next sessions, is keep your questions general. Do not present your specific case here. I'm not licensed in New York. I don't think you are licensed in New York either. So we might not really answer specific questions to your case and provide actual treatment or diagnostic recommendations on your case, but we'll keep things as general as possible, and I think in that way we'll help everybody. Let me click on this. All right. So I'll present and then you join me. Okay, perfect. So this is the MYD88 mutation. The MYD88 gene is a gene that has to do with activation of the immune system. In an individual without Waldenström's or without MYD88 mutations, whenever there is a viral, bacterial, or fungal infection, it activates MYD88 in the membrane of the cell. Now, MYD88 likes itself very much. So it looks, when it gets activated by an infection, it really looks for another MYD88 in the membrane of the cell and basically binds to each other. It connects to each other basically in 3 different spots. And when it does that, it really activates the signaling of MYD88. Now, what happens in patients who have the MYD88 mutation, which is located usually in 265, it's a specific spot in that gene, it doesn't really need an infectious process to activate itself. So it's essentially finding itself and activating and joining and activating and joining and activating, and do this continuously. So there's no rest, and this cell is perpetually activated on its own right. And we believe that that is one of the drivers of the malignant transformation on Waldenström's. Having said that, my personal opinion is that it's not the only thing that happens. I think it's necessary for MYD88 to mutate for malignant cells to develop, but it's not sufficient to make the cell malignant. I think there must be another hit, and we have reasons to believe that. In any case, if we do bone marrow biopsies in our patients, and we have done this in thousands of patients with Waldenström's at the Bing Center, we have been able to see that really about 93 to 95% of patients with Waldenström's would have such mutation. Now, this mutation is a point mutation. How do I describe a point mutation? If you imagine MYD88 as a sentence. Hi. If you imagine MYD88 as a sentence, and then you know that there's a mutation because one letter of that sentence is always misspelled. That is a point mutation, right? So it's always misspelled. You know where it is, you know what the misspell is, and it's always the same. And if interestingly speaking, it doesn't really matter if you are from the United States or Europe, France, Italy, Spain, Greece, Austria, Japan, or India. Those are just an example of the multiple studies. More than 50 studies have shown that patients with Waldenstrom's do carry this mutation. It's always on the same spot, and it's always on the same place. So it's very predictable that it's there, and unlikely to be random. We have had tested in a number of individuals without disease, and we don't find the MYD88 mutation just in the normal general population. I had my own MYD88 tested. I don't have MYD88 mutation. I do have my MYD88 wild type, which is no mutation. So, and this is a point of interest because it basically defines, from our perspective, the disease. You know, until before 2013, when this mutation was identified for the first time, the diagnosis of Waldenstrom's depended on having a bone marrow involved by lymphoplasmacytic lymphoma and the presence of an IgM paraprotein. And with those two criteria, you would make a diagnosis of Waldenstrom's. Having said all that, there are conditions that that mimic Waldenstrom's just by using those two criteria. IgM myeloma, which is more rare and more complicated, can have a lymphoplasmacytic picture in the marrow and the IgM that sometimes could be really high. Another lymphoma called marginal zone lymphoma can also have a lymphoplasmacytic picture, and they can also have a portion of those patients' IgM secretion. So, you know, can we refine the diagnosis? And I think the answer is yes. I mean, with the presence of this mutation, if somebody has those two criteria, plus the mutation in MYD88, I think the likelihood that those patients have Waldenstrom's is much higher. In my mind, it's over 99%. It's never 100, right? In medicine, nothing is 100%. But I think it's very suggestive of it. And understanding that, the WHO, the World Health Organization, in the classification of diseases for lymphoma, included now the presence of this mutation as a recurrent mutation for the diagnosis of Waldenstrom's. So, interestingly enough, there is a small group of people, I don't think this is working too well, a small group of patients will have a mutation in MYD88 that is not in the spot that we know it is in most patients. And that happens in about 2% or 3% of our patients. Now, so when I have a patient in my clinic, and I have to really think hard about a patient who does not have the MYD88 mutation, then I need to start thinking, right? Is this a patient with IgM myeloma? Is this a patient with marginal zone lymphoma? Is this a patient who might have a mutation in MYD88 but is not in the usual spot, right? So, you know, it is difficult in other centers. We do it in our center because we're an academic center. We can do it. And then what we do, we actually sequence the entire gene of the MYD88, looking for another spot that we are not designed. These tests that we have are designed to find the mutation in 265, but it will not find any other mutation anywhere else because that's not what we're doing, right? So we have to detect or look for other mutations, and we find them, you know, in about 2% of patients. But that means there's a small group of patients who meet the criteria for Waldenstrom's, but they do not have the MYD88 mutation. So that is a little bit more complicated, right? The WHO actually wanted to label Waldenstrom's as having the MYD88 mutation. If you didn't have it, then you didn't have Waldenstrom's. That's what they were proposing. But then we did some additional analysis, and we really found people who do have bona fide Waldenstrom's. They are not myelomas, they are not marginal zone lymphomas, and they do not have the MYD88 mutation, and it's not one of the non-L2C5P. So I think there's a group of people there, and I mean, we will talk about that a bit later. Those are what we call the MYD88 wild types. You know? In wild type, all it means is that it's normal. That's all it means. You know, either you are mutated and you have the mutation, or you're a wild type and you don't have a mutation. That's all it means. So I think it has reached a point in which MYD88 mutations has become one of the important markers for the diagnosis of Waldenstrom's. The second mutation that we have talked a lot about during this meeting is this mutation in CXCR4. CXCR4 is a gene that is involved with homing of cells in tissues and specifically in the bone marrow. So there is a specific, this is the entire molecule, there's a gene, there's a specific tail where all these mutations are found. And we, in our experience, about 40% of patients with Waldenström's can have a mutation in CXCR4. Now, the problem with these mutations is that it's not a, I mean, there are point mutations too, but it can happen in many different places in the same gene. So it's like having a sentence, but you could have up to 30 potential letters in that sentence that could be misspelled, and sometimes more than one in the same patient. So how you develop a test like the one you develop for MYD88, which is just almost always in the same spot, compared to this type of mutations, that's why it's going to be very difficult for the community to actually run this mutation testing. In the laboratory, we do it. In the research laboratory, we do it. There are some commercial testing that can be done, but I cannot tell you that the quality of that testing is validated and is great. There's a lot of false negative results, and we need to be very careful about that mutation for now. So the WHO has not acknowledged yet the value of CXCR4 mutations. The National Comprehensive Cancer Network, which is a national American guideline committee that I belong to, is saying, well, we could consider using it in specific scenarios. You know, so I think it's taking some traction, but we still need to learn a lot still about this mutation to actually make additional recommendations. So in our experience, we feel that patients with and without CXCR4 mutations do differ a little bit, clinically speaking. This is a table that I put together from at least 3 or 4 publications. As you can see, still data are mounting. We're still learning and understanding what having a CXCR4 mutation means. So based on this data, it's actually a study from us, the Germans and the French. So it's at least 3 data sets that are showing, I'm showing here. And it looks like the patients who have CXCR4 mutations tend to have a higher degree of involvement of the bone marrow compared to patients who do not have CXCR4 mutations. I mean, wild type, again, means that the gene is normal and is as expected. Patients with wild-type disease tend to have more lymphadenopathy. The patients with the mutation with CXCR4 is almost exclusively bone marrow disease. We see very little disease outside of the marrow. The levels of IgM in the serum tend to be higher in this population with mutations. And for that reason, I think they are more likely to present with hyperviscosity. So if I see somebody coming in to see me with no evidence of lymphadenopathy, with normal size spleen and liver, only bone marrow disease, very high IgM, immediately in my mind I'm thinking this patient can or might have a CXCR4 mutation. And there's a condition called acquired von Willebrand disease. It's a clotting deficiency that we can see sometimes in some patients with Waldenström's, and we have associated that also with the presence of these CXCR4 mutations. The risk of transformation to diffuse large B-cell lymphoma doesn't seem to be altered by the presence of the mutation, but again, more data is necessary. So this is an Italian study that was discussed during the meeting. And in this study, they put together a number of different patients. They analyzed CXCR4 mutations at different levels. But what we learned from this study is when they took these 81 patients with smoldering Waldenström's, right? They have the disease, but there's no evidence of anemia, there's no evidence of neuropathy, there's no evidence of hyperviscosity. These patients are largely asymptomatic. We call them smoldering or asymptomatic or inactive Waldenström patients. They followed those patients for about 4 years in average. And they basically saw how quickly these patients got to need therapy. So these patients were asymptomatic. We just follow those patients. We don't treat asymptomatic patients, as you already know. So they went to see how long it took for patients to actually need treatment from the moment of diagnosis until they actually became active and needed treatment. And what they saw is that it took about 4 years and some for patients with CXCR4 mutations to need therapy from the diagnosis time, in average. But the patients who did not have the mutation actually continue and needing treatment at a much slower rate. So obviously, 81 patients, you can say, well, this is not a lot of data, but it really tells us that maybe it is true that CXCR4 mutation patients do have a more active disease or will become more active a little faster than patients who do not have that. Again, this is not going to tell me that I need to treat a patient with CXCR4 mutation earlier, even if the patient is asymptomatic. That is not what this study means. But at least it gives us an idea that biologically speaking, patients with CXCR4 mutations might be a little bit different than patients without CXCR4 mutations. As you are aware, this is the study from Stephen Trion. This is the study that got Ibrutinib approved. And this is data that we presented last year with a longer follow-up. The paper in the New England Journal has about, I think it's about 2-year follow-up. In average, this is about a 4-year follow-up, so it's actually 2 years older. And this is more mature data, as we like to call it, more mature. So we basically, what we did, we divided the patients, those 60 patients in that study, specifically if they had the MYD88 mutation without CXCR4 mutation, which is this blue line on top. And then the patients who actually had the double mutations, the MYD88 and the CXCR4 mutation, that's the dashed line here, the red one. And then the patients who did not have MYD88 or CXCR4 mutations, which is this green line right here. So as we can see, up to 4 years, it takes CXCR4 mutated patients, for half of those patients to actually progress on Ibrutinib, it takes about 4 years. Again, that's an average, might apply or might not apply to you, right? This is a group of people, it's not an individual. But what we see is the people without the CXCR4 mutation, you know, it's about 5 years out, and just a quarter of those patients have progressed. So not only maybe patients will need treatment sooner, but if they get treated with Ibrutinib, that duration of that benefit or that response might be just a little bit shorter as well. In patients who were previously untreated, this is a paper that just came out a couple of months ago in the Journal of Clinical Oncology. We put about 30 patients. Based on the previous data that we saw that patients without MYD88 mutation did not benefit much from Ibrutinib, we did not include any MYD88 wild-type patient on this study. We didn't think it was an ethical thing to do. So all our patients have the MYD88 mutation, and obviously about 40% of those patients have the CXCR4 mutation, and the other group did not. So when we look at the overall response rate, meaning at least having a 25% decrease in IgM, they all responded. So that's nice, right? But when we went and looked into the depth of that response, you know, at least 50% decrease, that's what we call major, 50% decrease in IgM, 90% versus 70%. So there's a little bit of a decrease on the depth of that response. And if we look at 90% decrease on the IgM, which is the VGPR, or the very good partial response, 30% without mutations, 7% with mutations. So the depth of the response seems to be affected as well. And this is very reflective of what we saw in the initial study on patients who were previously treated. So it mimics very much that experience. And not only the depth of the response is affected, also how quickly we get to that response is affected. And this is an important point. How do you get at least a 25% decrease? It takes about a month if you don't have a mutation. It takes about 2 months if you have the mutation, so that's delayed. And a time until the patients decrease their IgMs by at least 50% is about 2 months. If you don't have the mutation, it's about 7 months if you actually have the mutation. So we need to be very careful about this, right? I mean, because Ibrutinib is going to start being used more and more now. People are getting more experience with it, and physicians might be far more comfortable giving Ibrutinib to patients with Waldenström's. And let's say somebody starts a patient on Ibrutinib, 3 months have passed, and there's not a great response. So the doctor or the patient might feel, well, I'm not responding, right? And I think the explanation could be because that patient might have a CXCR4 mutation, and we need to know that. So the patient might get there, which is going to take a little longer, right? So those are things that we're learning about CXCR4 mutations and how can they affect the disease and the treatment. And the graphic here on the bottom, these are the yellow lines are the hemoglobin levels if you have or did not have CXCR4 mutation. As you can see, the hemoglobin levels improve. There's no difference on the improvement of hemoglobin. So when the patients are anemic and they're tired, which is, I would say, 2 out of 3 patients with Waldenström's, regardless if you have a CXCR4 mutation or not, that hemoglobin is going to get better and it's going to normalize at the same rate. So patients are going to feel great. But the IgM levels decrease at a lower rate, right? So at least if the patient is having the benefit of the hemoglobin improvement, right, that could be an indication that the patient might respond, but that response might be a little bit more superficial. You might be aware or not of this new study that just came out as well, in which they added Ibrutinib to Rituximab, and they compared the outcomes of those patients to patients who got Rituximab with placebo, which means an inactive agent. So this is a study that we participated on and got published in the New England Journal of Medicine. And not surprisingly, we see that the addition of Ibrutinib to Rituximab improved the depth of the response. It really made responses faster, as you can see here. And that response actually lasts much longer. So yeah, I agree, Ibrutinib and Rituximab is definitely much better than Rituximab alone. But this study has been criticized to some degree during this meeting because what we would have liked, is actually have a third arm in which patients got Ibrutinib alone without Rituximab. So we can know what the benefit of adding Rituximab to Ibrutinib is, right? But obviously, it was not done. It's not going to be done. So we need to start kind of understanding what this all means for us. So specifically for CXCR4 mutation patients, we have here on the left patients without the CXCR4 mutation, the combination versus Rituximab alone. Obviously, much more benefit with the combination, a CR inclusive, a complete response here. For patients with the 2 mutations, very similar response rates, but when we look at the depth of the response, right, it's much more superficial. The depth of response, actually half of the patients got into a VGPR compared to the other group, 19% versus almost 37% here. So it looks like CXCR4 mutations also affect, at least partially, the responses to Ibrutinib and Rituximab. The group here on the right is the group without any MYD88 or CXCR4 mutation. I don't want to say any mutation because I'm sure they have other mutations that we are going to report at some point. But these patients did not have any of the MYD88 or CXCR4 mutations. Responses look very good. So in general, looks like Ibrutinib Rituximab is a very effective regimen. And we need to start thinking who might benefit from this combination and who might not. But CXCR4 mutations might also impact the depth of response in that context. And when you actually look at the progression-free survival, it looks very similar to all the groups, which is nice, right? Maybe the depth of the response is not going to affect the progression-free survival, the duration of that response, and that would be a nice thing to see. The issue here is the median follow-up is about 2.5 years, and I just showed you that patients with CXCR4 mutations, on Ibrutinib alone takes about 4 years for the average, for half of the group to progress. So we don't know exactly if these curves are going to change, a little bit as time goes by. And so we don't know that yet, right? But until the month number 30, there does not seem to be any specific differences on the groups if patients were treated with Ibrutinib and Rituximab. So these are the 4 questions that have been posed to us. So how can MYD88 and CXCR4 mutations be sequenced? How important is getting MYD88 mutation status in the diagnosis of Waldenström's? What is the role of MYD88 and CXCR4 in the management of Waldenström's? And how should CXCR4 mutations be used in making treatment decisions in patients with Waldenström's? So, Roger, would you like to, I think if you take the first question, then I'll take the second, and we alternate. Just your opinions and how these mutations can be used.
Okay, yep, thank you. So, first a couple of things to say. One of the things that we need to remember here is that these mutations are acquired and they're restricted to your Waldenström cells, so that's something that people frequently ask in the clinic. So these are not inherited mutations. These are things that you... Sorry? It's louder, sorry. Yeah, so the thing to remember here is that these mutations are acquired and they are restricted to your Waldenström cells. So that's a question that I'm frequently asked. So these are not inherited things. These are acquired and restricted to your Waldenström's B cells. So the question here is, how can MYD88 and CXCR4 mutations be sequenced? And there are significant technical differences here. So the MYD88 mutations Jorge alluded to is a single change, and as a consequence of that, it's much easier to detect in the laboratory. So it's much readily, it's more readily done in routine laboratories, and hopefully all of you will know your MYD88 status. I think it is, certainly from my perspective, an absolute requirement in terms of establishing a diagnosis. Before we knew about this mutation, essentially, we didn't really have any proper pathological criteria on which we could make a diagnosis. So I think we do need to do that. It's very simple. It can be done, and there are relatively straightforward methodologies that we can use that are also pretty sensitive. So we can detect the mutation down to around about 0.1% of cells and maybe lower. So that actually means you can detect the mutation in the peripheral blood for many patients. So CXCR4 is more of a challenge. And the reason for that is that as Jorge showed you, there are loads of different mutations. So the letters in the sentence can be changed at the start, at the middle, at the end of the sentence. They're quite varied. They're not present in all the cells. And some patients may have more than one mutation. The biological significance of those mutations can also vary. So some of those mutations result in a completely defective protein, and some of those mutations result in a protein that kind of works but is a little bit defective. So we're still learning about the significance and the complexity of this. So one of the problems from a laboratory perspective here is that it's a challenge to find it. So the way that we historically look for mutations is by a technique called Sanger sequencing. And that's effectively a way of photocopying the sentence so that you've got multiple copies and then you can detect it. Now that has limited sensitivity. So you probably need to have around about 20% of cells with that mutation in a bone marrow sample to be detectable by Sanger sequencing. So if the mutation is not present, so if you have 20% bone marrow infiltration and you have a CXCR4 mutation in half of your cells, then you will not be able to detect that CXCR4 mutation by Sanger sequencing. So false negative results are common. So we need to develop methodologies that provide a more sensitive way of doing that. We can do that by homing in on specific CXCR4 mutations, or by doing higher technology methodologies such as next generation sequencing. So there's a lot of challenges for the laboratory in this perspective. So we also need to be able to have methodology that allows us to know that if you've had your mutation tested in San Francisco, then your result is the same as if you've had your blood tested in Kansas City, New York City, London, Rome. So for things to become truly clinically significant, there has to be a robustness to them, a reproducibility, and a knowledge that if we do detect a mutation, it is there and it's clinically significant.
Thank you very much. So I think Roger kind of answered the second question too. I mean, how important is getting the MYD88 mutation status for the diagnosis of Waldenström's? And I would say at this time, it's probably mandatory. The techniques have been very more refined. They have been standardized now. We use a technique called PCR that basically looks for a mutation that we know already exists, you know. So the problem with PCR is that it will not detect mutations in MYD88 that are not located in 265, right? So if it's a negative value, then, you know, give me a call, and then we'll try to see how can we make this happen. But yeah, I think having the MYD88 mutation at this time is probably one of the most important tests that patients can have, in addition to obviously their blood counts and their IgM levels and, you know, all the additional testing that we do to evaluate patients with Waldenström's at diagnosis. But I think the presence of these mutations in the right context, clinical laboratory context, increases the likelihood of actually having an actual diagnosis of Waldenström's macroglobulinemia. You want to address the third question?
Okay, so the third question here is, what is the role of MYD88 and CXCR4 mutations in the management of WMLS? Again, that's a challenging question, actually, and it's one that we've been discussing quite extensively during the course of our meeting. So I think having the MYD88 mutation in the right clinical context clearly clinches your diagnosis. So that's part of your management, is making your diagnosis. If you make a correct diagnosis, you're halfway there to managing things appropriately. I guess the question here is, can we use these mutation profiles to make clinical decisions? And that's actually quite a challenging thing. So on the one hand is, and I guess to some extent this will depend on the specific scenario for the patient, where they are in their treatment journey, what treatments they've had previously, what their clinical features are, what their healthcare system they are in. And obviously one of the things that we battle with when we're thinking about how we use these things is our decision-making processes are actually very profoundly affected by our own healthcare system. So Jorge and I practice in hugely different healthcare systems in terms of provision of drugs and reimbursements, etc., and that has actually a profound effect on the way that we practice. So my own view at the moment is that I certainly do not use the CXCR4 mutation status to make a treatment decision for the patient. As we've seen, that CXCR4 mutation status can have an influence on your clinical features. So if you do have a mutation, CXCR4 mutation, you're more likely to have a high level of paraprotein, high chance of hyperviscosity. What we've got to remember here is that if we think that CXCR4 mutation is biologically important, which it almost certainly is, there is a big difference between something that is a prognostic factor and something that is a treatment-directing biomarker. So we need to be sure that our interventions, if we are making them on the basis of the mutation status, is the correct thing to do. Because there will be, with anything that we think is a prognostic factor that influences your outcome, there will be people who will have a genomically good profile who may not behave in a way that we would wish. And clearly we always see patients in whom we think are not going to do too well, who defy the odds and do well. So we need to couch it in those terms.
Thank you. So, and then at the end, and then we will open, you know, these topics specific for your questions, is that how should CXCR4 mutations be used in making treatment decisions for patients with Waldenström's? And again, I think it's very challenging. And I think it's challenging because, you know, when patients come to our center, we do have the research funds to be running this fancy genomic testing, but this might not be available outside, you know. And we don't have really any data until today that supports that CXCR4 mutations are associated with a worse survival. We don't have these data. Actually, all the studies have shown that even if patients have the CXCR4 mutation, the survival is the same as not having the CXCR4 mutation. What it does affect, though, is the response to Ibrutinib, and this is what I've shown you. We don't know much if there's any impact on other treatments. There's a study from the Mayo Clinic that actually supports that if we use cyclophosphamide, dexamethasone, and Rituximab, then really having or not having MYD88 or CXCR4 mutations matter much. There is a recent study that is under review from a multi-center study using bortezomib and Rituximab, and it looks like in that setting, it doesn't really matter if patients have CXCR4 mutations or not. Our study from carfilzomib and Rituximab didn't show any difference between having CXCR4 mutations or not. The study with ixazomib showed that if you have a CXCR4 mutation, maybe you are a little more delayed in terms of getting into a response, but didn't seem to have any impact on the progression-free survival. The data on venetoclax that you guys are going to be talking about later shows that maybe patients with CXCR4 mutations have a little bit more delayed responses and maybe more superficial responses too, but that's an ongoing study, so the data are not mature enough. So I think we are still learning about this. And I think I would have to echo what Roger said. I don't think is, at the moment of diagnosis, I don't think it's necessary to know if a patient have a CXCR4 mutation or not. Now, my preference, and this is supported by the NCCN guidelines or the National Comprehensive Cancer Network guidelines, is that if patients are about to get treated and Ibrutinib is one of the options, then at that moment it's useful to consider having the CXCR4 mutation testing done. There are, as I said, a couple of commercial platforms that can be used. One of them is a laboratory called Genomics. The other one is Foundation One. There's two different platforms that actually check for CXCR4 mutations. At Dana-Farber, we have our own platform. It's called the Rapid Heme Panel, and we use that. It is commercially available too. But the problem is the sensitivity. The problem is if we find it, we know it's there. But if we don't find it, and the patient didn't have more than 20% disease in their marrows, then we don't really know if the patient actually have it. We just couldn't detect it. And that's the problem that we're going to be seeing more recurrently. Now, as we understand these mutations better, we are identifying, as Roger mentioned, groups of mutations that behave in different ways. In some of those mutations, it seems to me that the ones that are maybe more clinically relevant for Ibrutinib might actually be amenable to develop PCR testing for those. And that would be a good thing to have, but I don't think we are ready for that right this minute. So I would say then MYD88, yes, please have it done. I think it's needed for diagnostic purposes, and obviously to decide sometimes, as we presented, patients who do not have the MYD88 mutation do not respond very well to Ibrutinib, so other options might be necessary at that moment. For CXCR4 mutations, I think if Ibrutinib is a consideration for therapy, then at that moment might be necessary, but not so much if patients are considering bortezomib, Rituximab, or cyclophosphamide or bendamustine as their main treatments. And with that, I would like to open the floor for questions about mutations. There are microphones here. If you want to speak and you cannot walk, just let us know so we can actually hand you down the...
Hello.
Thank you.
My name's Peter, and...
sorry, please.
I'm sorry.
No, please, it doesn't matter. Go ahead. Right. You started.
I fall in that 2% category. I don't have any of those identified mutations. So am I an orphan now? I mean, what should I have refined molecular identifications done? What's the thoughts?
So if a patient is not in need of therapy, right? I mean, we can
I've gone through 6 chemo cycles already, okay. And I brought my IgM down from like about 4,300 to 352 or something like that.
Good.
So I mean, I'm functioning now.
Yeah,
but,
so if the treatment has been done and you are on a response, then obviously you might not need patients who are on a response might not need to be treated, for the time being. So I don't think it's absolutely necessary at this time to actually have that testing done. But at some point in the future, when there is a relapse or recurrence of the disease, it might not be a bad idea to have it done now. If you know that you didn't have the MYD88 mutation and the amount of marrow disease was substantial in your marrow, then maybe it really is not. Or you might have another mutation that is an MYD88 mutation, but it's in a different spot. So a sequencing of the gene might be something you could consider.
So where do I go for that?
You can come to Dana-Farber. We do that here. We do that in our institution, or you can discuss this with your doctor and see if they can actually do the sequencing locally. As long as they do it appropriately and follow a nice technique, it shouldn't be a problem.
Okay, thank you.
Yes.
Dr. Castillo, you said that for the phase 3 Innovate trial that there wasn't an Ibrutinib-only arm. There actually is arm C. I'm on it, one of 30 patients that seem to be conspicuously absent from the recent report. There was no mention of any of the results. I'm thinking it's maybe because we aren't truly randomized in that we're all people that where Rituximab didn't work. Do you know, was there any discussion of that arm? Because as you said, the real question is Rituxan monotherapy isn't something that's prescribed that often these days, so comparing Ibrutinib only to Ibrutinib Rituximab seems to be a relevant question. And as far as I know, my arm was it was only published once after about a year, and I was wondering if there's any discussion this week about arm C and the results that of Ibrutinib only.
Yeah, so the arm C actually was published before the randomized component.
Yeah, in the Lancet.
And obviously it included patients like yourself in whom the randomized component was felt inappropriate because you wouldn't have responded to Rituxan and the placebo. So as far as we can tell, the arm C results are very good, and obviously you're here and your testament to that, I guess. And broadly speaking, the results of that seem to be in line with Steve's pivotal study. So in terms of the appropriateness of the standard arm, that actually has proved a challenge for pretty much all WM trials, because choosing a standard of care in this setting is very difficult, because you ask 100 different WM patients what they had as their primary therapy, you get 10, 12, 15 different answers. So by definition, your standard of care in a randomized trial will by definition be a compromise. So it will always be open to criticisms and weakness. It's where we are. It was discussed with the FDA, and it was what felt to be appropriate. So it is where we are.
Yeah, so specifically to that question, I mean, we didn't have any more mature data to be presented at this meeting, but we felt that it was very reflective of what the initial phase 2 study showed in terms of response, and even in terms of how CXCR4 affected the depth of that response too. But that's pretty much all we have at this time.
Hi, Jorge. Pete Skinner here. Question on depth of response. Do you have any data that relates depth of response, your complete response, very good, blah, 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 with progression-free survival or time before the next treatment? In other words, when you get a CR, should you expect a better PFS? That's one question. The other question is, well, that's the most important one.
So yes, we do have some data on this, but the data is from retrospective studies in which patients receive rituximab-containing agents. This is a paper that Steve published a number of years ago. So we took older patients who got rituximab-containing regimens, I think CDR, fludarabine R, and things like that. And then we did see that the depth of the response was actually correlated with the duration of that response.
Right.
There are a lot of caveats with an analysis of that nature, and the reason is how long it took for patients to actually get to the depth of the response, and if that plays anything to actually how long that response is going to last. So it's a difficult way, it's a difficult analysis to make. We do have some data from prospective studies, specifically the carfilzomib study, we did that, and the ixazomib study, we did that, and we saw that the depth of the response correlated with the progression-free survival of patients as well. So I think there's some to it. Now, I don't think we have done this with Ibrutinib alone. You know, I don't really know. But we're working on it. So that's a project that we're going to be working on it, trying to gather our experience with Ibrutinib and see if actually the depth of the response has anything to do with the duration of that response. But at this time, we don't know the answer to that. But I do believe that the depth of response correlates with duration in patients with rituximab-containing agents.
And one other related question, should a patient diagnosed with Waldenstrom's and recommended watch and wait, should you wait till you're just about lying on the ground, or should you intervene earlier so that you have a better chance of a complete response early? I mean, I waited until I could barely climb the stairs. Maybe I should have started earlier.
Yeah, well, that is a difficult answer, difficult question. So the reason that is a difficult question is because people feel different. I see patients in my clinic with hemoglobins of 9. They will meet criteria to be treated, and they feel great. They go to the gym 5 times a week, which is much more than what I do. And I'm like, why am I going to treat you just because your hemoglobin looks bad, but you feel well? On the other hand, I do have patients who come to see me with hemoglobin of 11, and they are really, really short of breath and fatigue. So it's very subjective, right? It's not so objective as just saying, oh, hemoglobin is below 10, we should treat everybody. So it's never like that. My opinion is we shouldn't treat patients who are completely asymptomatic. And we shouldn't wait until the patient's performance is so affected by the disease that they cannot do their activities of their daily living. So that typically puts a gap, right, in between being completely asymptomatic and being very, very sick. So somewhere in that spectrum, you know, patients should be treated. And it is not a line that you cross, right, based on the fact that the example that I just gave you with hemoglobin, it's not a line that you cross. It's actually an area that you get in which is reasonable to treat. And some patients are like, you know what, doctor, if I sneeze twice, just treat me. I don't want to have too many symptoms from this. And that's the patient's perspective. Some patients are like, you know what, you don't treat me until I come here in a wheelchair. So those patients want to be treated later in that spectrum. So I think it's a lot of communication between patients and physicians in terms of understanding the right timing to treat. But I think the two divisors are asymptomatic people should not be treated. People we shouldn't wait until the patient is too sick. So somewhere in the middle. And that is a conversation.
But you don't have any data that shows that the ones that you treat early has a much better chance of a complete response.
We don't have that as of now. Yeah. I don't know if you have any experience on this.
No, my perspective is the same. It's a personal decision between you and your physician as to the timing of therapy, and to a certain extent it's a sort of philosophical argument, and there will be a whole range of things that might impact on your timing of therapy. The good thing about WM is that typically we will be having those conversations over many clinic visits where we can discuss it and come up with because things typically evolve relatively slowly, and we can discuss that and work out what people's own views are. Some patients are more proactive than others. I'm personally fairly conservative and tend to watch and wait quite long. Sometimes the treatment is worse than the disease.
Gary. Hi. Do either of you have any preliminary thoughts excuse me, about the difference in the types of CXCR4 mutations, specifically nonsense versus frameshift?
Yes. So, I mean, that's an interesting concept, and I think Roger alluded to that during his part that he was speaking. So, not all CXCR4 mutations are created equal. We know some mutations are different than others. There's a type of mutation called frameshift, in which you have a sentence, and then you have a letter taken out of that sentence, and the whole sentence is moved. Then you don't understand what it reads, but it's actually a molecule that is there, semi-complete and maybe semi-functional. There's another type of mutation in which the the half of the sentence is gone, disappears, falls down. So that's an incomplete truncated protein, and that's what we call nonsense. So just to give you an idea, there are at least 2 different subtypes of mutations. And our experience is that they actually behave differently. I think clinically speaking, they present very similar, but at least to Ibrutinib, it seems to us that nonsense mutations tend to have lower rates of response than frameshift. Actually, when we looked at our frameshift patients, they behave very similar to not having CXCR4 mutation when they were treated with Ibrutinib. But again, I'm talking about 20 patients who were frameshift and about 60 patients who were nonsense. So it's a very small group of people. We're still learning about what exactly that means. I don't think we are at any level need to use that information to make any treatment decisions right at this minute. I think we are about, please go ahead. Yeah, we have.
I want to understand, I heard that it's mandatory for you to see mutations to diagnose with Waldenström. But then you say that you treat those people who don't have mutations and you see less response. What are you treating them for then?
Yeah, so if I understand correctly, so in patients with wild-type disease, meaning they don't have MYD88 or CXCR4 mutation, we treat them the same. We just follow them until the point in which they need to be treated. And at that moment, we decide in terms of what to treat. And we have been treating them with either bendamustine rituximab or bortezomib rituximab or cyclophosphamide rituximab. We just don't use Ibrutinib on those patients. That's the only difference in terms of the management.
But you call them Waldenström or LPA?
We still call them Waldenströms, as long as we don't have any other, but we do a much better job trying to really rule out other potential problems. We want to make sure that the patient doesn't have a myeloma. We want to make sure that the patient, there's no other evidence of extramedullary disease that could potentially tell me that this patient has marginal zone lymphoma, for example. So I tend to go a little further out to make sure that we are actually treating a patient, clinically speaking, a patient with Waldenström's.
Okay, thank you.
All right, thank you very much for your time. I think the next session will start in about 2 minutes. Thanks.